Welcome to 12 Lead Part 7, The Imposters. I'm going to talk a little bit about things that might show up on a 12 lead that can fool people into thinking they're seeing evidence of an ST elevation MI when actually there's something else going on. It's important to keep in mind that in EMS particularly, we aren't using the 12 lead to diagnose chronic conditions. We aren't using it to find some of the things that I'm going to talk about. But you may pick up on something important through that process. But we are looking for these imposters because we don't want to call something a STEMI when it isn't. We don't want to activate the cath lab and tie up those valuable resources for a patient who isn't going to benefit them. So there's a value in being good at knowing what is and isn't a STEMI. So how do we know what's a STEMI? I've said this before in several places in my videos, but remember, it's all about the story. Earlier, video 5, I talked about using the 12 lead as a diagnostic tool. If you think the story fits an MI, you got to look deeper even if you don't have STEMI evidence. Now I'm talking about the reverse. Now I'm listening to a story, looking at a patient, and I don't really think it's an MI, but I'm seeing something on the 12 lead that seems to suggest STEMI. It might be a STEMI. Not every STEMI is going to present at the stereotypical presentation, but it also might be something else, and that's the prompt we should consider to think about looking a little closer. So there's several things that can make this challenging, and here are some of the most common examples. This is not an all-inclusive list, but these 5 are probably the most likely things you're going to see, especially the first 3. That's ventricular rhythms or pacemaker rhythms, left bundle branch blocks, left ventricular hypertrophy, benign early repolarization, and pericarditis. And especially the first 3, as I mentioned, because a lot of our patients who are in that age group, in that demographic that's likely to have a cardiac issue, may present with some of these as part of their history, which can skew the results of our 12 lead. So we'll talk about those first 3 first. So the first is ventricular rhythms. And at first glance, you notice that this looks kind of big and dramatic, and there seems to be a lot of ST changes across the strip. But if you look a little closer, you notice the very first column on the left is a sinus beat. It's a P wave followed by a QRS and a T, and then the next 4 complexes are all ventricular beats, and then we have 2 more normal sinus rhythm beats, and then it goes back into ventricular. Based on what I said in an earlier video about needing good, clear cardiac cycle in each of the 12 views, this 12 lead is really not useful at all in terms of making any sort of significant interpretation, but it's easy for our eye to get drawn to the big dramatic ST changes that come when there's a big dramatic QRS. Here's another example of wide QRSs, rather dramatic changes. If you're focusing or looking for ST elevation, you may quickly look at lead 2 and 3 that have dramatic ST elevation following that wide QRS. But if you look a little closer, what you discover is that this is a paced rhythm, and you can see the little pacer spike, and the pacer spike is followed by a wide QRS. So that wide QRS is a ventricular conduction pathway that's being triggered by an artificial pacemaker, and because of the odd wide pathway of the electricity through the ventricle, it is likely to produce odd and different ST segments and T waves. And in this case, it appears to look like ST elevation, which it is, but it has no significance in terms of an MI. It's simply a reflection of a altered electrical pathway through the ventricle. Bundle branch blocks. In another video, I talk about bundle branch blocks and how we identify them. And one of the key characteristics is that they have tall or deep QRSs in addition to them being wide. And again, when you have a wide, ugly QRS, you're likely to have a pronounced and dramatic looking ST segment. So in this case, if you look at V1 through V4, it appears that this patient has a massive anterior MI. In reality, they have a bundle branch block, and this is not evidence of an MI. Now remember, if it's a new onset left bundle branch block and they've never had this pattern before, the most likely explanation would be that an MI is causing it. But it's also possible that a patient who has had a bundle branch block for years will have a 12 lead that looks like this. So again, we go back to the story. If I'm looking at a patient and I think their story sounds like they're having an MI and I see this, I'm concerned and I'm going to look a little bit closer. If, on the other hand, I have a patient who's complaining of something non-cardiac related and I find this, I'm not going to latch onto this as a diagnosis and assume they must be having an MI. Left ventricular hypertrophy is the next one, and it's very common. Anybody with chronic hypertension is at risk for developing hypertrophy, and in hypertrophy it does not typically widen the QRS unless there is also some other conduction problem going on, but it does deepen or increase the height of the QRS. It's recognized, we spot it, identify it by this increase, and there's a 3-step formula, but it's really pretty simple to spot. So in this example, you can see very dramatic, deep, and tall QRSs. That's your first clue that this is probably ventricular hypertrophy. The 3-step process that they use for making that determination is that you look in V1 and V2 first, and you pick the deeper of those two, in this case V2, and you measure how deep it goes below the baseline. In this case, it's about 30 little boxes, which is the number we attach, and then we remember that number. So that was in V1 or V2, we pick the deepest. Then we go to V5 and V6, we pick the tallest, in this case V6. So we measure that. Again, we have about 30 millimeters above the baseline. That's a tall QRS. We then add those two numbers together. And anytime that sum is greater than 35, we should suspect left ventricular hypertrophy. In this example, the two added together equals 60. This is an example that makes it really easy to spot hypertrophy because the QRSs run into the line above and below. In most of these, you could probably just measure one and get close to that 35 millimeter measurement. The more important thing to focus on is that those deep QRS complexes, even though they're narrow, produce ST elevation and large T waves. At first glance, that can look a lot like the ST elevation associated with an MI, but it's not evidence of an MI, it's evidence of left ventricular hypertrophy and does not meet STEMI criteria. The next one I'll mention is not as common, but it's benign early repolarization, and it's exactly like it sounds. Benign meaning it is a clinically insignificant finding that occurs in some patients. Early repolarization simply means that that early repolarization process starts earlier than in most, and it produces some characteristic changes to the ST that can be mistaken for ST elevation. It's a normal variant in some patients. It's not easy to identify. If it's there, it can produce ST elevation. It can produce tall T waves. It's usually, but not always, seen in the anterior and lateral leads. And it's most often in males, 20 to 40 years of age. It's more common in African Americans than other races, and it's more common in people of thin build. So that's kind of the key here. If you're looking at a 20 to 30-year-old thin male who is not having a cardiac crisis and you stumble across this on an ECG, you shouldn't change gears and start assuming that this is an MI. This is just one of those interesting findings that shows up that looks a lot like ST elevation. One of the things that makes it look different is this characteristic look at the J-point. They call it a fish hook, and these are different variations of that idea. It doesn't have the classic appearance that a cardiac ischemia and injury pattern would cause on ST segment. Back to the example I showed before, you can see I've highlighted a couple of them here that just have a funny little fish hook, kind of an up and down look, a concave rather than convex shape to the ST segment. This is not at all characteristic with what we typically see in the ST elevation of an MI. The next one I'll talk about is pericarditis. Again, this is all about identifying the story because it can be deceiving. Pericarditis might be viral, bacterial, metabolic, can be secondary to a number of things, including recent cardiac surgery, a recent MI, IV drug abuse, number of other things. The clinical presentation certainly may include chest pain because pericarditis is inflammation of the sac around the heart, so that can absolutely produce chest pain. And because it's irritating significant portions of the myocardium, it can often produce ST elevation on an ECG. Really important that we look at the clinical presentation. And that classic presentation of pericarditis is sharp stabbing chest pain rather than the stereotypical pressure or tightness of cardiac chest pain. It's often accompanied by a fever, which is rarely the case in an acute MI. It can be localized. Again, each of these could be similar to cardiac chest pain, but in this case, often if you ask a patient where it hurts, they can point to one location, which is also not typical for cardiac pain. And it might be relieved by movement, respiration, position, swallowing, also not typical of an MI. It may radiate to the base of the neck, which sounds very similar to what we characterize cardiac chest pain going to the neck and the jaw, in this case the neck and perhaps the shoulder blades. The reason it's confused for MI is that it can produce ST elevation in any lead. It can produce ST elevation in all leads, which is a good clue because an MI won't do that. And it may not be anatomically grouped. In other words, you might see ST elevation in 2 or 3 different leads, but they aren't contiguous leads and they aren't looking at the same part of the heart, which does not give any indication of a blocked artery. And that fishhook appearance is another clue. Here's an example of pericarditis. You can see that there is ST elevation in a number of places, dramatic ST elevation in V1 through V6 across all of those. And if we look a little further, there's ST elevation in 2 and 3, and even some in AVF perhaps. So this is significant. You would look at this and potentially think this is a huge septal, anterior, lateral, and inferior infarct. Not a very common occurrence to have all of those areas infarcting at the same time, but more importantly, the story isn't going to fit. We look a little closer and you can see that in that lead, you even have that little fishhook appearance. It's a funny looking ST elevation, not the type of elevation you typically would see with an MI. One other change is medications. Beware that some medications can change repolarization patterns. Some of the antidysrhythmics, and specifically digoxin is one that's known for this. So any digitalis preparation will do this. And what's interesting is it'll produce this characteristic ST depression, this little sag, and some of our cardiac monitors will identify it and will pop up in the interpretation to identify that there is a non-specific ST change, possibly a digitalis effect. I've seen that on machine interpretations a number of times. One other that I'll mention is not really an imposter for an MI, but that is worth mentioning is external interference, just as a reminder that the machine sometimes misinterprets the things that it's seeing in ways that we can recognize better. So here's an example. This is from a physio control monitor, and the arrows I highlighted across the bottom is the machine sensing some sort of electrical impulse at a very fast rate. And if you look at the ECG tracing, until you look all the way over at the right-hand side, you don't see any evidence of electrical impulses, but you do in those last 3 seconds, and they correspond to the little arrows on the bottom. The only explanation the machine's algorithm could come up with for these little spikes of electrical activity is that it's a demand pacemaker. Well, if you know anything about pacemakers, you know that makes absolutely no sense because this patient has a rate of about 68, meaning they don't need a pacemaker firing, and the little arrows you see are going at a rate of about 300 and they're irregular, none of which makes sense for a pacemaker. What this actually was is a patient who was laying in bed with an electric blanket over the lower half of their body while the 12 lead was being acquired. The ECG was picking up the electrical impulses from the electric blanket, and the algorithm had no idea what it was, so it labeled it as a pacemaker. In summary, when we're thinking about imposters or imitators, it's important to remember that a variety of these things can produce ST elevation or depression, making us think that we have a STEMI when we don't. But a number of these things can also hide ST elevation or depression, such as bundle branch block. The most frequent imitators or imposters that you are going to encounter are left ventricular hypertrophy, which makes those tall and deep QRSs, bundle branch blocks, which create wide QRSs, and paced rhythms, which also create wide QRSs. The take-home message there is anything that makes the QRS deep, tall, wide, odd, ugly is likely to change the ST and T wave. And that means in those circumstances, we have to be suspicious of whether or not that ST elevation is actually telling us anything about a STEMI, but perhaps just telling us something about the conduction pattern. If a QRS is wide, think about a bundle branch, think about a ventricular paced rhythm. If the QRS is narrow, look for hypertrophy, think about pericarditis, think about early repolarization or one of those other examples. And above all, pay attention to the story. If the story fits and you think your patient is having an MI, provide the best cardiac care you can and get them to the right resources. If this patient's story doesn't sound like an MI, don't get fooled by the machine. Don't get fooled by a tracing into trying to make it into something it's not. I'll throw in one more here that is really, I say difficult, but probably impossible imposter to identify, just because it's an interesting case. And this was a 78-year-old female who had recently lost her husband, was very upset, anxious, understandably, and presented with chest pain, shortness of breath, diaphoresis, hypotension. And on our exam, we found this on her 12 lead. And you can see that she's got significant ST elevation in most of her V leads as well as in lead 1. She fit all the criteria and our diagnostic criteria for a STEMI, and we made her a STEMI activation and took her straight to the cath lab. In the cath lab, they put a catheter into her left coronary artery, and what we have here is beautiful circulation. Absolutely no obstruction, no blockage anywhere. So then they proceeded to check the right coronary artery, and again, we have absolutely no indication of an occlusion, a blockage of any kind. Her arteries are flowing beautifully. What this patient is actually suffering from is Takotsubo syndrome, which is broken heart syndrome is another name for it. And that name is not the name of a doctor who came up with this. It's actually, a Takotsubo is a name of an octopus trap in Japanese. And it's given that name because the ventricle, the left ventricle, takes on a shape similar to that. It's stress-induced in most cases. It's called a stress-induced heart failure. And the ventricle simply doesn't pump effectively. It doesn't squeeze effectively, and there's very little outflow, resulting in classic MI-type symptoms and even classic ST changes on a 12 lead. Here's an image where they've injected blood into the ventricles. You can see the pumping action of the heart, and you notice that the ventricle is sort of resembles that shape that octopus trap, and you can see that the neck of the ventricle, so to speak, is moving, but the rest of the ventricle is barely squeezing at all, which is why her cardiac output was so dramatically impacted. In that case, she was taken to the ICU, she was monitored, and like in most cases of this disorder, she recovered over time. It's not a well understood phenomenon. It's not well understood, the pathophysiology. It's more common in women than men. It's usually stress-induced or stress-related in many cases, and it's usually a survivable event. But unless the patient tells you they have that history, you're not likely to be able to discern the difference, and it's appropriate to take that patient to the cath lab because they fit all the criteria. Kind of the take-home message is 12-lead interpretation can be challenging. I think it's worth our effort. I think it's worth our effort because it can make a significant difference in our patient's outcome. We can benefit our patients tremendously, and I appreciate you listening to my videos, and I hope this helps.